Talwar sir and invite him to speak on his experience of ranibizumab as first-line agent in retinal disorders. Dr. Dinesh Talwar is one of the most respected and most sought after vitreoretinal surgeon as a speaker and an academician who can really tear us apart, all of us.
Yes. Thank you, Prashant. Intravitreal agents have revolutionized the treatment of retinal diseases. And this journey began long ago. This is my disclaimer and my financial disclosure. Before I start, I want to acknowledge my debt of gratitude to Professor Bipin Chandra, who is no more, but who gently guided and encouraged me to continue my pursuit for successful management of age-related macular degeneration throughout his life. And actually, his lifetime over the last 20 years before he passed away was actually coterminous with the development of anti-VEGF drugs in this country. The anti-VEGF journey actually began with Marina and Anchor, which showed sustained visual acuity gains with monthly ranibizumab. And for the first time in world literature, we managed to have improvements in our patients with age-related macular degeneration, rather than consoling them that your rate of deterioration will become less, and therefore you will go blind more slowly than you usually do. This regime was monthly and was the gold standard till some time back. And at that time, when this started, ranibizumab was the only drug available, initially for exudative age-related macular degeneration, and then for various other forms of choroidal neovascularization, diabetic macular edema, then developed for BRVO and CRVO with macular edema. So if you talk about first line, we all started with ranibizumab as first line for a long time because there really wasn't a second line. However, now we have other drugs which have come. Other than bevacizumab, we also have aflibercept, and we have brolucizumab, and we have faricimab. So there's a lot of treatment modalities which are available to us today. How have these advances in management protocols changed the current approach to treatment? Well, as far as therapy for with anti-VEGFs is concerned, the optimization of management for exudative AMD is a combination of the drug used and the schedule of retreatment. And a lot of parameters are used to decide that, how you will use them. The ranibizumab as a first-line therapy for exudative macular degeneration was found in the EXCITE study to be adequate for 40% of patients on a quarterly basis. That means the 12 weekly injections that we talk about, even with ranibizumab, the same are possible in 40% of your patients. How you use it today, I'm not talking of the old times, I'm talking of now, depends on the type of lesion. If you talk of type 2 CNVMs, what we used to call classic CNVMs before, ranibizumab is extremely effective, and even today is my first-line drug. For type 1 CNVMs, aflibercept is probably more effective than ranibizumab, but you could use ranibizumab for both initiation and maintenance of therapy in patients who have economic constraints, and I will explain to you how. It's effective in many of these patients, but may require more frequent injection use, maybe once in 6 to 8 weeks, though, as I showed you, some 40% of the patients may have adequate response to even 8 weekly or more treatment. The RIVAL study compared ranibizumab with aflibercept on a treat and extend basis and found that the visual outcomes were more or less the same with both the drugs. So was the number of injections needed, and most importantly, the number of patients who went up to 12 weekly or more injections was also more or less the same. Around 30 to 40% is the generally the figure given. Today, how do I manage my patients? I manage my patients with a loading dose, either of ranibizumab or aflibercept. I give 3 injections. If the lesion becomes dry, I have 2 options. For my one-eyed patients, I keep them on a treat and extend treatment, whereas with my 2-eyed patients, I would put them on what we call the PRN treatment. If a recurrence occurs within the next 3 months or whenever I treat it, if it doesn't occur, after 3 more months, I will increase the duration between follow-ups, initially to 6 weeks, then 8 weeks, then 10 weeks. But once in 12-week follow-up must continue lifelong. Patients who need a PRN treatment more than once in 8 weeks, say 6 weeks, 4 weeks, those are the ones I would consider a change to aflibercept. Just to show you, I mean, you may be wondering, ये तो होता ही होगा फिर सब में? No. You see this patient who had an occult CNV with a SRF, and this was one of my patients whom actually after giving the first injection, I had no option but to stop because it was absolutely okay. And for the next 1 year, the patient did not need an injection. So there are patients who will respond to maybe even 2 doses. Even I could not complete a loading dose because there was no further need for an injection. On the other hand, after your first 3 loading doses, there will be patients who are stable but not dry. They have some fluid. Intraretinal fluid is there or a little bit of subretinal fluid is there and it refuses to go away. Now you give, next 3 months you give the injections, and if during this period, the lesion dries. Now, if it dries, you go back to the first algorithm where you treat with PRN treatment. But supposing it doesn't dry in 6 months, now at the end of 6 months, I will consider, if it is stable, no change in the OCT, no change in vision, I will put this patient into a treat and extend regime. Slowly increase the duration of interval by 2 weeks. With ranibizumab, you should not increase by 4 weeks. You should increase the interval only by 2 weeks at a time and see how the patient is doing. And then if I can reach a quarterly injection, that once in 12 weeks, that's a very good level, and you can maintain the patient at that level. If, however, the injections are needed more frequently, you may need to change the pattern to aflibercept. Now, once you've treated, you gave the injection, still some fluid is there, you treat it again, still some fluid is there. Now you treat it, fluid's gone. Should I stop the treatment? No. You give at least 1 more injection so that you have 2 consecutive OCTs with no fluid, no change, before you say, now I can put on a PRN treatment and not treat. The important thing is, even with ranibizumab, if you are optimizing the frequency of monitoring, your results will improve. So if you say, okay, you are okay now, come once in 3 months, you are doomed to failure, more or less. The Sailor trial showed that the patients followed up 3 monthly, whatever were the gains in the beginning, at the end of the loading dose, were all off by the end of the year. So what do you need? You need monthly follow-ups. Not monthly treatment, monthly follow-ups, and very stringent guidelines for retreatment. If the patient has any decrease in vision, any OCT fluid, evidence of new fluid, any increase in thickness, any new macular hemorrhage, no fluid, but macular hemorrhage, small hemorrhage, new hemorrhage is there. So fundus photograph is important. Or any subjective evidence of macular fluid, treat this patient. Your vision results will improve. Remember, now see this, I was going to show you when I use it as a first line basis. This is first line. You have a patient, this is a classic CNVM, type 1 CNVM, given a loading dose 1, given 2. No further treatment is needed. This is a type 2 CNVM. Excellent response to treatment. This is another patient. This was a myopic CNVM. You see a CNVM here, disappears. 1 more injection was given. Next 1 year, no injection needed. And then developed an early recurrence, again treated, disappeared, lesion is all right. And then again for 3 months, nothing, given 2 injections, and has been all right for 4 years. In myopic CNVMs, ranibizumab alone is more than sufficient in most of the patients for a long, long time. This is another patient who had an inflammatory CNVM. He was all right. He had only this kind of scar tissue, developed this activity, needed 4 consecutive injections, and then became all right. And subsequently has needed only 2 to 3 injections per year to maintain. So inflammatory CNVMs is another condition where ranibizumab is adequate for treatment. You don't need to go anything further than this. And finally, there are some patients who have scar tissue with activity, like you see over here. Now you may say, why are you treating? This patient has 624 vision. This is good vision. You want to salvage this vision, you want to maintain this vision. And so we give this patient ranibizumab. Once in 12 weeks, she needs an injection. She's maintaining between 618 to 612 vision and is gone on for the last 5 years. So you can, again in these patients, maintain patients on ranibizumab alone. Now you may say, well, this is your anecdotal evidence. Is this actually working? Let's look at this. This is a study of long-term outcomes of treat and extend regime using ranibizumab, aflibercept, and bevacizumab. And you know what they found? No difference in visual outcomes with the number of injections between the agents used. Not only that, they also showed that the kind of fluid was also the same. The degree of persistence of the fluid was also the same, regardless of whichever drug was used. But most important, what made the difference? What made the difference was the number of injections, the duration of treatment. The longer the patient was treated, the more the number of injections, the better the response. So the eyes that gained more than 2 lines, were those which received more injections. The eyes which had visual acuity of more than 220 by 200 at the last follow-up had received treatment over a longer period, average of 3 years versus 2 years for the others. Greater number of injections, 23 versus 14. So it is not which drug, it is use the drug properly. So ranibizumab is adequate if your patient can't afford any other drug, and you can get the same outcomes. And this is a study from a Western country. They found giving 4 to 8 weekly injections of only ranibizumab, they could maintain better than 20 by 40 vision in 40% of the patients. 43% of these patients had better than 612 vision. And more than 64%, 2/3 of the patients, had better than 618 vision. What more do we want? So don't tell your patient that if you can't afford aflibercept or faricimab, you're gone. No. You have lots of options available that can keep your patient going, and ranibizumab is a good option for these patients. So the basic principle you need to keep, no tolerance for fluid. We don't tolerate either intraretinal or subretinal fluid unless it's completely unresponsive to treatment, and then it's a stable situation, accept that. Sub-RPE fluid, don't bother about it. You don't have to go after it. It doesn't go away with ranibizumab. But any increase in fluid must not be tolerated. So aggressive treatment can give you effective results. But the important thing is regular follow-up, high index of suspicion for retreatment. Remember, ladies and gentlemen, eternal vigil is the price you pay for maintaining vision in patients with CNVMs. What about diabetic macular edema, the second big group? The utility was shown by the RESTORE, the DRCR-NET Protocol I, the RISE and RIDE, and Protocol T. All these drugs have shown its utility. The important thing to remember, the key message here is it's a finite disease. Number of injections decreases with time if proper treatment is given in the beginning. It's more intensive in the first year, less in the second year, and by the third year, there is resolution in many of the patients, or more than 60% or so. In fact, 25% of your patients will not need any injections in month 3 or 4, and these are elite responders. These patients will only need around 4 injections or so in the whole year. But this does not hold for everybody. There is another 25% of patients, there is another 20% of patients who will not respond. So don't keep wasting their money. Those are the patients you must shift to steroids. And there, a combination of the steroids with anti-VEGF agents may give you the best results. Which drug to use? Now you say, well, ranibizumab, old drug, does it work as well? Well, the question was answered by protocol T. In patients who have better than 618 vision, both ranibizumab and aflibercept are effective. So these are the patients in whom I normally will start with ranibizumab, because there's no point in going to a higher level of drug when the lower one works. For patients whose vision is less than 618, aflibercept works better, and the initial aflibercept followed by ranibizumab for maintenance may be a better alternative. But patients who cannot afford aflibercept should be put on ranibizumab, not on bevacizumab. Why not on bevacizumab? This is to answer that. If you see the drying of the lesion in patients who have very good vision, this is protocol T. The drying with bevacizumab is around 67 micron, whereas with both aflibercept and ranibizumab, it's around double of that, 119 and 129 micron. So this is the reason why only in those who can afford nothing else, those are the patients where you go to bevacizumab. In the rest, the choice is of ranibizumab. Now, in patients who have poorer vision, but the thickness is less than 400 micron. Again, ranibizumab and aflibercept are equally effective. So even in patients who have, say, lower vision, normally you say lower vision, aflibercept, but no, lower vision, but the thickness is, say, less than 400 micron, ranibizumab is as good as aflibercept. And this is all protocol T. This is not me speaking anecdotally. In patients who have a thickness of more than 400 micron, those patients aflibercept is better. So how do you go about now? You may have patients who had more than 400 thickness. The patient says, I can't afford so many drugs. I can't afford monotherapy with aflibercept. Remember, when you combine macular laser, focal macular laser with ranibizumab, the results are as good as aflibercept monotherapy. So, and this is again protocol T, not personal information. You see this here? Vision is less than 20/40, focal treatment done, same results in all the three groups. Vision is less than 20/40, but no laser done. Obviously, the best results are with aflibercept. So patients whom you want to do, and in fact, in our country, to bring down costs, I would suggest the best option is combination of anti-VEGF first, bring down the edema, focal macular laser then, and then followed up with PRN treatment with anti-VEGF agents. Ranibizumab would be adequate. Now, it's not as if you don't get results here. You see this patient, he developed macular edema, one injection ranibizumab given, responded. Incidentally, I was interested in showing this because I keep getting people showing patients on brolucizumab. I gave one injection, became all right. This is ranibizumab, man. Treatment-naive patients with ranibizumab also respond as well. It's just that the number of patients who respond like this will be less. But you can get the same good results with any of these drugs. So, one injection, patient responded. What about this? Horrible edema. Ranibizumab given, improved, given another one, improved further. Normal foveal contour. 3 injections it took. Normally they say 5, 6. Yes, in today's world, after 3 injections, if your patient is not responding, give an injection of steroid. Don't keep on waiting. Now look at this. This patient was worse, needed 5 injections. Edema given, little better, not much, not much. Finally decreased, came back, gave one more injection and responded. So 5 injections. Now how do you manage DME? In DME, if your vision is better than 6/9 or better than, and near vision is better than N8, you don't need to do anything. But if the vision is either less than 6/9 or near vision is less than N8. You see, this is very important. People don't talk about this near vision part, but remember, what happens in a macular disease? The near vision goes first. And what happens? He can't work. And you say, no, you are 6/9, I won't treat you. Hey, he's N12, man. Treat him. So either of these are indications for treatment. Then you see after 1 month, this was DME, now we come to BRVO. In BRVO, if the patient, the same actually holds for DME also, don't treat patients who have good near and distant vision. Treat them only if the vision goes down below 6/9 or below N8. But in patients who come to you with BRVO, now this is even more important because there is a tendency, edema hua, treat kar diya. No. If he comes within the first month and the near vision or distant vision is good, don't treat. He will become okay. If the near vision or distant vision are bad, then you need to give anti-VEGF agents. Presentation after 1 month, you see, he came to you after 1 month, near vision, distant vision bad, treat. If it's good, you don't need to do anything. So any increase is treated beyond 6/9 or N8. Now people will say, hey, how can you not treat? Now look at this. This is the Comrade study, not my data. It says if the patient presents even up to 60 days later, no difference in outcomes, right? So why are we in such a hurry? Most of these cases of BRVO will recanalize on their own, so don't be in a hurry to treatment. This was a patient who came with 6/12 vision, so we decided to treat. And you can see injection given, patient became all right. So here it's PRN treatment, 1 injection, patient's okay, forget it, no more. Now, after that, you follow up the patient. If he's okay, you don't need to treat. If there's a partial resolution or no resolution, you would need to give more injections. This is to show you another patient who did not respond. 1 injection, 2 injections, 3 injections, 4 injections, 5 injections. And finally, we were forced to give Ozurdex. And with Ozurdex, the edema started coming down. So that will happen once in a while, even in BRVO, and that will happen with any of the drugs that you're using. So in BRVO management, initially ranibizumab, recurrence, ranibizumab. Third time recurrence occurs, give a combination of ranibizumab with quadrantic laser, especially if on FA you have more than 5 disc areas of capillary non-perfusion. And after that, if the patient still gets a recurrence, you have to think whether to shift. So this is just to show you one more patient, 1 injection given, improved a little bit, then became okay with the second one, stayed okay after this, again a recurrence, was treated, became all right, again recurrence. This time he was given a quadrantic laser. Along with that, became all right. Next recurrence, a macular grid was done, a modified grid. And then he has stayed okay since then for the last 7 years. So you have to have that patience to treat. When you are following up patients with recurrent treatment, on recurrent treatment, if the deterioration is less than 1 line, you can be conservative. But if it is more than 2 lines, you have to give either anti-VEGF agents or add steroids and use a treat and extend regime. Remember, now again you'll say, laser ka kya role hai? Again, not my data. Look at this. The brighter study showed that patients who had ranibizumab with laser, who had more than 12 months of duration, did better than those who did not get ranibizumab. See, this is the group without ranibizumab. This is the group with ranibizumab with laser. Again, in this situation, ranibizumab and aflibercept both work, and Ozurdex is a second line. Last group of patients, central retinal vein occlusion. This is a more dangerous situation. You do need to treat. Basically, the mainstay of treatment here, as ranibizumab was demonstrated by the cruise trial, and aflibercept also works. Both are effective, but it's not that ranibizumab will not work. It will work in this condition. Just to show you, this patient got 1 injection. With 1 injection, became all right. Became all right, got a recurrence sometime later, was again treated, again responded well, and then stayed all right. He stayed all right because the vein recanalized, not because the drug did anything. And the same applies regardless of whether you're using ranibizumab or aflibercept or any other drug. We don't make the patient okay. The recanalization, upar se aata hai, that makes it okay. So the initial treatment is anti-VEGFs and steroids in non-responders, laser in case these are ischemic. Ladies and gentlemen, I conclude by saying ranibizumab is still available to you as first-line therapy in many situations, including type 2 CNVMs, as I showed you, DME, RVOs, and in all patients requiring anti-VEGF treatment who have economic constraints. Thank you very much. Remember, a targeted approach, keeping in mind the lesion characteristics and the response of the lesion to treatment. Both are needed to ensure the highest quality of care at least cost to the society. Thank you very much.
That was typical Dr. Talwar taking help of evidence-based medicine. Just one point, probably the safest anti-VEGF currently in case of systemic problems, MI and stroke and all, is still Ranibizumab, right?
Yes, so
that
now
is
remember this. This is a very important thing that Mahesh is talking about. The only proven, validated drug for safe injection in a patient with a recent MI or a recent stroke is 0.3 milligrams of Ranibizumab. None of the other drugs have been tested for that, so we don't know whether any of the other drugs are effective. And that's exactly what I do. If I have a patient with AMD where I have no choice but to go in, even if the patient was on aflibercept, I will shift him back to Ranibizumab, 0.3 milligrams for some time, and then shift back again.
Yeah. Especially now, a lot of apprehensions are there, especially in nephropathy cases and all these things. This appears to be the safest one.
So
Then,
one question also I had. You spoke about whenever recurrences and need of further injection, the criteria was OCT based more than 100 microns, and also you said that subjective fluid assessment can be also a
Yes.
criteria. What do you mean by that?
Yes. So you know what happens is, see, this is very important. This last bit cannot be done by a physician who's seeing the patient for the first time. But when you've been seeing the patient month after month, you know, hey, this is not quite right. There seems to be some microcystic fluid here, which is not enough to form a well-defined cyst, but there is a problem. Even in that situation, it's better to be safe than sorry. That's what I mean. It's not that there is, see, what it means is, there's these very, very fine microcystic changes. It's not enough to now cause a well-defined 100 micron increase in thickness. But when you compare the two, you say, no, this is not quite okay. Something is worse. That's what I mean. And that can never be done by somebody who's seeing the patient for the first time, which is why it's very important that your patients follow up with you regularly.
If I have to add something on this, forget you seeing anything. It is the patient, if especially a one-eyed patient, he will tell you there is a distinct difference in what I saw last week, and they will come and say, give me the injection. You don't even have to worry about it. You don't even have to do your OCT.
Best
So you will
patients
have
are
that
one-eyed.
occasional patient.
The
Best
one-eyed
patients are
patient
one-eyed.
will follow up, will be after your blood, and
So-
he would want it.
So Dr. Bipin Chandra, whom I talked about, would actually come and say, he said, Dinesh, I think it's time for another injection.
Another injection.
And sometimes I wouldn't be sure. But after the injection, he will say, "Theek ho gaya."
And if you wait within 1 or 2 weeks, you will start seeing changes in the
And
OCT.
yes. So don't ignore the patient. Especially if it's an intelligent patient, don't ignore the patient.
They come with the injection. They are clear, now I need the injection, forget the OCT. Especially
Only the second day, I mean, one eye is normal, there is problem. In those cases, I think the PRN appears to be the best. The other thing is DME and RVO, we need not be very stringent in our management. It is pardoning type of disease. And in many of the RVOs, I give one injection. Even if there is recurrence after 1 month, the vision may not become 6/60. It may be 6/9, 6/12. Then you observe it.
It may not even fall.
Yeah. So, especially TVO and all, there is no point in giving continuous injection. Final result will be due to recanalization of the,
See, with
collaterals.
BRVOs, don't be aggressive.
Yeah.
It's very important. For BRVOs, don't be aggressive. CRVO, you can be more aggressive. In BRVO, supposing you've given 4 injections and you find he's come back, just see if you don't give the injection, what happens.
This will remain.
Very often you'll find nothing happens.
Yeah, basically neovascular AMD,
He just stayed
PCV
there
and
with a little bit
CRV
of
are the
edema.
aggressive diseases, not the RVOs. DME is somewhere in between. But sir, very well highlighted that since this neovascular AMD spectrum, PCV and wet AMD as well as CRVO are aggressive diseases, we need to deal with it aggressively initially. This is something that ophthalmologists sometimes tend to be loose on. And they talk of cost cutting from from day one, but basically if you're not aggressive initially, you actually land up increasing the cost for the patient.
Yeah, so remember what I said. Very, very aggressive, not treatment. Very, very aggressive monitoring.
Yeah, but the initial,
Every 4 weekly, see your patient.
Yeah.
If you find anything negative, treat. Do not leave it alone. You will ensure that you give adequate treatment if you do that. And if you don't do that, unfortunately, you will give suboptimal treatment and the patient will have suboptimal results. And then you'll say injections don't work.
What
And then you'll say Ranibizumab didn't work.
Arnab says is absolutely correct. Some of the general medical retina specialists, they give one injection of aflibercept, then 3 months later other one. Then the patient will come, though injection, there's no change. Because the protocol is totally wrong.
So most of the time patient will come to me, मुझे तो 5 इंजेक्शन लग गए,
If you
कुछ
see
भी नहीं
the
मिला.
gap,
So ऐसे कब लगा था पहला? इसे 3 साल पहले. लास्ट इंजेक्शन कब लगा था? 6 महीने पहले. तो मैंने कहा वो तो वेस्ट पेपर बास्केट में फेंक दिया तुमने.
In fact,
that's the
we
thing.
go to the new generation injections just to increase the duration of activity, not because this first generation Ranibizumab is bad. It is still good. We are all using that.
Yeah. Basically, the newer anti-VEGFs are not better in efficacy. It is better in allowing us longer
Durable.
intervals.
Durable.
Prolongs our
And
the
see,
time
the
between actions.
basic thing is you want to pick up the ones who need that longer duration. I told you 20% will not need anything else. They'll be okay with this. Now, why do you want to subject those 20% also to the most expensive drugs? First, try the simple thing. It doesn't work, you can always go to the higher thing. That's the important thing.
Okay. So we'll continue. Okay,
One
last
statement.
question.
Sometimes, I mean, if you feel that this is a very aggressive disease where you need a newer anti-VEGF to help you out, and the patient is his financial status doesn't allow you to continue with that, sometimes you can open with a strong anti-VEGF, the newer anti-VEGF, and then you can come down to
I
Ranibizumab.
said that for DME.
Yeah.
That if you see the curve of the improvement, it's a little better with aflibercept than with Ranibizumab. But the plateau level is the same with each. So you can start with aflibercept and then shift to Ranibizumab.
Yes. So
in diabetic macular
I
edema.
was trying to say the same.
Okay.
Correct, sir.
So